Good morning, everybody. My name is Cyndi Cummings, and I am an expert in older adults in the city of Austin. And I have a good friend of mine here today, Dr. Mark Carlson. And Dr. Carlson is a fellowship-trained, board-certified geriatrician, internist, and oncologist. And he's the founder and medical director of Be Well MD. Be Well MD is a medical practice designed specifically for aging adults. Primary care services are provided in patient homes, and Dr. Carlson and his medical team serve as a hub for their patients, surrounding them with services and support needed to remain safely in the home for as long as possible. Convenience, access, and customized senior care are all the hallmarks of Be Well MD. Clinical research has been a cornerstone of Dr. Carlson's career. With his focus on senior health, Dr. Carlson recognizes that advanced treatments are desperately needed for dementia and other senior-related conditions. This is now a primary focus, as his role as a geriatrician and the driving force for creating Be Well clinical studies. He is the founder, the medical director, and the principal investigator for Be Well clinical studies. So how are you today, Dr. Carlson?
Thanks, Cyndi. I'm doing really well. I'm enjoying the summer heat.
Oh, I think, what did they say, 110 today?
I don't know what it'll be, but it'll feel like that, I'm sure.
Yeah, so we're going to stay inside if we can. Well, today we're talking about Alzheimer's. And can you provide a brief overview of Alzheimer's disease and its impact and how it affects the actual individual and their families?
Oh, sure. Alzheimer's disease is a progressive degenerative neurologic disorder. It primarily affects memory, but it affects essentially all, or can affect all, areas of cognition. Your thinking, your ability to solve problems, your ability to plan and take care of yourself. Those are all components of the disease, but usually it starts with memory changes. The disease is caused, we think, by deposits of abnormal proteins in the brain, proteins that you may have heard of, amyloid plaques and tau tangles. That is the primary hypothesis. And there is mounting evidence that that is part of it, but there's additional evidence that that's not the whole story. And so some of you may have heard that Alzheimer's disease is type 3 diabetes, meaning glucose metabolism or dysmetabolism may be an underlying contributing factor as well. There may be vascular components, there may be other elements, and that is still being worked out as we speak with the research that we participate in. The effect on individuals and families is profound. In Be Well MD, I take care of elders. I think the average age of my patient population is north of 80. And yesterday was a typical day, and roughly half of the patients that I saw doing my rounds were affected by some form of dementia, and most of that is Alzheimer's disease. It takes away independence, and it is a huge burden not only on the individual, but especially in the later stages of the disease. The burden on the family and the caregivers is so significant. I suspect most in your audience have had some sort of a direct experience with Alzheimer's disease and understand what I'm talking about. So that's a quick overview.
Well, I appreciate that. Well, Alzheimer's is often in the news with updates on the disease and possible preventions and treatments. Can you highlight some of the most current news?
Yeah, so you may have heard about a new drug called Leqembi or lecanemab that was just approved by the FDA. So that's the exciting news, and I'm sure we'll talk about that a little more later. But in addition to the work or this recent approval by the FDA of Leqembi, there's ongoing work looking at the core cause of Alzheimer's disease and other dementias, but there's significant work also looking for biomarkers. Right now, the diagnosis of Alzheimer's disease is not simple. We don't have a simple test that you, Cyndi, if you wanted to know if you've got Alzheimer's and you come into my office, it would take multiple visits, multiple tests of different form in order for me to determine whether or not you have Alzheimer's. And knowing you the way that I do, I'm pretty certain you don't. But Alzheimer's disease that starts out very subtly, and in fact, the changes in the brain that occur in the beginning happen perhaps 10 or start changing 10 or 15 years before the diagnosis can be made. And so the nuances around diagnosis is one area that is very important in order for us to help understand who has it and who doesn't. And so that, along with these treatments that are finally proving to be effective, are probably the mainstays of the modern research into Alzheimer's disease.
So biomarker would be a blood test. Is that
a biomarker? Could be a blood test or a test that we run on some other tissue in the body. Okay. We already have some early biomarkers for this disease. In the past, we used to have to do lumbar puncture to sample the fluid around the spinal cord and the brain in order to test. But now we do have some markers in the blood that are finally correlating with the diagnosis and allowing us to rely on a blood test, or the blood test can help confirm the diagnosis. It's still not perfect, but we're moving in that direction.
Great. Well, you mentioned, I'm going to try to say it, Aduhelm.
Yeah. Aduhelm, and
Aduhelm.
The Aduhelm is the trade name for a drug, a monoclonal antibody called aducanumab. And these are, it's a mouthful to say these drugs. But anyway, aducanumab is a sister drug to Leqembi. A couple years ago, the pharmaceutical team of Eisai and Biogen jointly developed Aduhelm, or aducanumab, and they demonstrated that it was able to clear plaques from the brain. And then the follow-on to that is that we think if we can clear the plaque from the brain, that the brain would start working better. And in some respects, that hypothesis may be true. But with aducanumab and many of the other drugs that have not worked in Alzheimer's disease, I think that part of the reason that they're not resulting in the kind of benefits that we want to see is that we're starting the treatments too late. Meaning the damage has been done, and even though we can stop further damage by clearing out the plaques, it's still too late, or it is too late, and and the brain is not able to recover from the damage that was done over those preceding 5, 10, 15, 20 years or more. And that is one of the changes that is happening right now, meaning we're recognizing that our focus was on late stage disease, and we really need to be focusing on early stage disease in order to change the paradigm and really get to the root cause of this problem and start making some real differences. So anyway, Aduhelm, getting back to that story, it was approved by the FDA almost exactly 2 years ago.
Okay.
And the story is interesting because the benefits were modest and there were risks associated with Aduhelm, just like with any drug. But unfortunately, the way that the FDA approved it, it was a fast-tracked approval. It never was It never achieved traditional FDA approval, and therefore Medicare never provided coverage for it. And the complexities with all that meant that it was never a drug that could be really utilized in the clinic efficiently. And so the Biogen, about a year ago, they decided to remove it from the market. And Eisai, the sister company, then continue, or not the sister company, Eisai is the collaborating company with Biogen, and they work together on Aduhelm and Leqembi. And so Eisai continued the work on Leqembi, and at the beginning of this year, they had presented their data to the FDA, and the FDA gave them a fast-tracked approval. And Eisai immediately then went to the FDA to get traditional approval. And that traditional approval was associated with the Medicare agreeing to cover. And that's probably one of the biggest findings from last week. So on July 6th, the FDA gave traditional approval to Leqembi, where Aduhelm never got that designation.
So you're talking about cost and how it impacts regular people being able to take the drugs. If it's not approved by Medicare, then only the wealthy could have potentially taken advantage of that.
Exactly. And now that we've got Medicare approval, the traditional or the private insurance companies will probably follow and allow for appropriate coverage for those individuals who need the drug.
That's great. Well, and getting that kind of approval just last week, what kind of impact do you foresee on the treatment landscape of Alzheimer's disease?
So this is not going to be a rapid change. Alzheimer's disease has been sort of orphaned over my entire career up until now. Because we don't have a treatment that can really change the trajectory of the drug, doctors and clinicians have not been focused on making that diagnosis early. Because even if we know that you've got Alzheimer's, up until now, there was nothing we could do to change your trajectory. And so therefore, we would only focus and start really caring for those individuals when they were in the middle and late stages of disease. The fact that we now have a disease-modifying drug, it's now going to be important for the entire world of medicine to shift our thinking and start focusing on disease before it gets too late in the process. Meaning finding those individuals who truly have Alzheimer's in the early stages. That's where Leqembi was proven to be beneficial, and that's where we as clinicians need to start looking and making those diagnoses early on so that we can offer treatments to as many of those who need it as possible.
So it's almost like a breast cancer marker, isn't it? The genetic testing that females do when they have that certain breast cancer. I don't know what that's called. When you have that marker, then you get tested more often. Is that right? So you're looking for earlier diagnosis so that you can have a better outcome.
Yeah, and I'm glad you made that analogy, Cyndi, because I think it's very apropos. In the world of oncology, we've recognized for decades that the earlier treatment, the earlier you diagnose and treat, the more effective your treatments are. And that paradigm is also true for dementia. And now that we've got a treatment that can modify this, it's going to be important for the primary care physicians, the internists, the geriatricians like me, to start asking the question early on, do you have an early form of dementia where we can change your long-term prognosis. And you mentioned the hereditary breast cancer, those individuals who carry the BRCA1 or 2 abnormality. We do test for that in women without breast cancer in order to identify their risk and then give them prophylactic prevention options. And I think that, or I hope that in my career, we finally get to that point with Alzheimer's disease, where we are diagnosing this in a preclinical or early clinical stage and allowing us to treat the disease and maybe even cure it, but the cure is a long ways off. We're going to be treating just like cancer and turning it into not a cured disease, but a chronic disease that we can manage better.
What should people know about early detection and being able to be a part of that diagnosis of Alzheimer's disease early on?
Yeah, and that truly is a dilemma because of the orphan status of the disease that I mentioned before. The clinical community, the doctors, the nurses, we have not developed the nuanced skills that we are going to develop now very rapidly, I hope, to help guide individuals in the right direction. So, for instance, you have your mother, or you have your grandmother, or your spouse who is getting into the later years of life in the 70s or 80s, maybe the 60s, and the cognitive capacity naturally declines a little bit, primarily surrounding the speed of processing, so that things aren't as quick as they used to be. And that is normal, but differentiating that normal drop off in the speed of processing as compared to pathology, such as true memory dysfunction and true cognitive dysfunction in those early phases, is very, very challenging. And so it's something that when you misplace your keys once or twice and you start thinking, well, maybe I need to go to the doctor and get that assessed. Why did I misplace my keys? Probably not. Meaning that happens to everybody and that's normal. But if these things are happening more and more frequently, it is something that is worth mentioning to your family doctor, your internist, your geriatrician, in order to help him or her understand what is going on. And then the physician will hopefully be able to do the right kind of testing, the right kind of cognitive testing. And really, it does take a clinician to help sort that out. So don't be afraid. Mention it to the spouse, mention it to the family, mention it to your doctors. And all of them combined will help lead the individual, hopefully, to the right place.
I think if you can frame it that if we do something now, it will help stunt the disease or stop the progression, something to show them the benefit of it. But it seems that when you start some conversations like this, I have a lot of friends with parents right now, and they're talking to me about it. There's an obstinance. There's I'm totally fine. And the other, spouse is going, oh, she's not fine, so it's almost like they're very defensive, and it's very hard to even get them to the doctor. But I think if we can reframe it, to where we can say the benefit is, you could stop the disease if you had it with this new drug, that
Yes.
maybe we can start to get people into the doctor who should be going.
Yes, and that, I think, Cyndi, is exactly why we're talking today, to help people understand that there are things that can be done now, and the earlier we understand the true issue, the earlier we can intervene, and the more benefit the individual can sustain from any treatment that is recommended.
Yeah. What are the side effects from this new drug? Are there any?
These monoclonal antibodies have, just like Tylenol, a long list of things that it can cause. These are infusion medicines. They have to be given intravenously in order for them to work.
Okay.
And so the immediate side effects are things like infusion reactions. And those are very manageable. They occur in a minority of the patients who receive it, and we've got good clinical strategies to prevent and treat that if it happens. So that's probably the immediate thing that we worry about. And then the longer term thing that you're going to hear about is the swelling in the brain or the small hemorrhages. And those two, those are more worrisome, but also they're things that we can watch for and hopefully manage. And so overall, the potential benefit for this drug, because the disease is so devastating, the benefits outweigh the risks. And in my opinion, these risks can be managed. In my time during my time in oncology, I used drugs like this routinely, and drugs that were much more toxic, much more difficult. And we learned how to use them. And now we can use that experience to help manage the treatment of Alzheimer's.
Do you have this drug available now? So if somebody came and they were diagnosed, would they be able to start using it today?
Leqembi was just approved. The question is, if you started your treatment today, would Medicare cover it? And the answer is they probably would, but the insurance process is going to make this, practically speaking, that it's not going to be available widely for another several weeks. Medicare has to go through their bureaucratic process of assigning the proper codes and getting that set up so that whenever we do use the drug, they approve it and will reimburse the clinical center that administers the drug.
How expensive is it if I wanted to pay out of pocket?
It's a daunting number, but in context of medical care overall, it's pretty modest, meaning $26,000 a year drug cost.
Okay.
But if you compare that to some of the rheumatoid arthritis drugs, the treatment for dialysis, for instance, and the treatment with some of the oncology drugs, we as a society have decided that the price point of about $100,000 annually for a treatment to extend life for 1 year is worth paying for.
Wow.
And in this case, we're going to be well under that threshold, probably in the neighborhood of $50,000 to $75,000 annually for a year of life extended. But there's other components that go into this, because there's going to be substantial cost savings as you look at the caregiving or the reduction in caregiving requirements that this drug will provide individuals. So it's not only the life-saving and the independence-saving nature of the drug, it also is going to be a financial benefit for society at large because of the enormous cost of caregiving for individuals with late-stage dementia.
Right. Well, if I am a caregiver, how can I support my loved ones when they're going through treatments such as using this type of drug? What can we do to help them?
Help the caregiver?
No, I'm the caregiver. How can I help the patient? How can I support them?
Oh, okay. Yeah, caregiving is so vital. And I think the discussion that we had earlier around the shame and the fear is important on the education front to help individuals recognize that now it's important to go into the doctor and try to try to determine whether or not you have Alzheimer's disease, so that treatment can be started earlier. So that education component is number one. Number two, for somebody who does have Alzheimer's disease, in the early stages, they're still going to be fully independent, and they can maintain that independence hopefully for many years. So in those situations, I think encouraging them to make preparations for what's coming 10 years from now, i.e. talk to the caregiver or talk to the families and encourage them to share their wishes, talk about the disease, talk about advanced care planning, and let their wishes know. I think that would be the number one advice for anybody with early stage disease. Talk about this with your family. That'll help get rid of their fear. It'll help get rid of your fear. And any internist, family doctor, or geriatrician, I suspect would be more than happy to moderate that conversation if that was needed. Certainly, I do that on a regular basis. Every member that I meet in my practice, we have a advanced care planning discussion early on in order to understand what their wishes are now, while they're competent and able to fully convey to us what they want, so that in the event that they can't, they can no longer tell us, then we know from what they've told us before what to do.
Mhm. Well, what do you see about the future of all these different kinds of drugs? What advancements do you foresee in the field of Alzheimer's treatment in the near future?
Yeah, my suspicion is, just like in the world of oncology, that we will continue the drug discovery process and use all of the molecular biology tools that we have to uncover newer and better treatments and combination of treatments. And then also the paradigm is shifting so that we identify these biomarkers, so that, for instance, somebody like us, Cyndi, you and I, that nobody has concern about Alzheimer's disease, but maybe we do have it and we just don't know it. And we can discover the biomarkers, so we could do a simple blood test or a simple genetic test to determine whether or not we're gonna, our risk is high or low of getting it in the future. And that's the research that is ongoing right now and will continue and make the diagnosis and early diagnosis and treatment of this disease better and better as each year goes by.
Mhm. Well, what message would you like to give to individuals and families currently battling Alzheimer's disease?
Talk about it. Talk about your fears, talk about your concerns, and then don't hesitate to talk about it with your doctor. Your doctor can push you in the right direction or lead you in the right direction to help make that early diagnosis if it's there. And now that we've got a treatment and there's more coming down the pipeline, now that we have those therapies, we really need to know early on who needs them and who we should offer this treatment to.
Do you think there's going to be a limit in the drug? Is it going to be hard to get, do you think?
I hope so. I hope so, because that means Eisai, the drug manufacturer, and Biogen, they understand that there are literally millions of Americans, and worldwide tens, if not hundreds of millions of people out there right now with early stage disease that could benefit from this. So I hope that we have a shortage, and Eisai, I'm confident that they will, that they're prepared for this upcoming need, and will be able to ramp up production to meet the need as it evolves.
It'd be a good problem to have, is what you're saying.
Yeah, exactly.
Yeah.
Well
Yes.
said. I could have been much more concise.
Well, Dr. Carlson, let's just remember that early detection and timely intervention can finally alter the course of Alzheimer's disease. If you or a loved one are experiencing changes in memory, thinking, or behavior, don't hesitate to reach out to your physician. And please don't let fear or uncertainty hold you back. This is a pivotal moment.
Yes.
Thank you so much for your time today. It was great to talk to you.
As always, Cyndi, thank you and be well.